Thanks everyone for joining tonight. Welcome to our monthly Ampath virtual fireside chat. And thanks for tuning in from Indianapolis, Eldoret. I think we have a few late night folks from Eldoret or wherever we may be in the world. I think most of you know, but I'm Adrian Gardner, the Executive Director of the Ampath Consortium and Director of the IU Center for Global Health, joining from Indianapolis. Although I just recently returned from Eldoret, where I used to live for about 7 years prior to moving back to the US in 2020. As many of you know, in Eldoret at the IU House, we've held these weekly fireside chats since the 1990s to provide a space to learn and reflect with our trainees and visitors. And we're grateful that technology allows our Ampath community to keep up these discussions monthly, keep us connected and share program updates and lessons learned like what you're going to hear about today. So tonight we're going to hear about some of the pediatric oncology work. As many of you know, Ampath's motto is leading with care. And we strive very hard to respond to the needs of the communities that Moy University and Moy Teaching and Referral Hospital serve. This mission grew significantly in response to the HIV pandemic in the early 2000s, but quickly has led us into cancer and oncology work as well, starting in the late 2000s. I always remember that Bob Einhertz used to carry around a photo of a young boy who had Burkitt's lymphoma and said he wouldn't stop until we could cure kids with Burkitt's in Kenya like they were being cured in the United States. Cancer is projected to become the leading cause of death in sub-Saharan Africa, but as recently as 10 to 15 years ago, there were really no cancer treatment options available in Western Kenya. So today you're going to hear about how Ampath has changed that, specifically for children, because of the great work of our Kenyan colleagues, Festus Striguna and the consortium partners together. More than a decade ago, physicians like Dr. Pat Lair, the former director of the IU Simon Cancer Center and now director of the Center for Global Oncology and Health Equity within the Simon Cancer Center, began collaborations to build the capacity to screen, diagnose, and treat cancer in Western Kenya. Since then, we've really helped to build a system of cancer prevention, early detection, and treatment. And in 2016, we opened the Chandaria Cancer and Chronic Disease Center at Moy Teaching and Referral Hospital in Kenya, which really serves as the sort of capital, if you will, of the tertiary level care, and serves as a learning institute to train the next generation of Kenyan caregivers, and really provides a home for robust research and care. Just a month or two ago, actually, the Chandaria Center started offering radiotherapy, which is development despite COVID. Major progress, been years in the making, but finally there. And actually the work has begun on a second bunker and the procurement of a second linear accelerator. So we're very excited that that service is expanding. Will create a lot more therapeutic options for our patients. Today, we have with us Dr. Terry Vick and Dr. Tyler Severance, who will share their work in recent years on using telehealth platform called ECHO to improve the diagnosis of childhood cancers throughout Western Kenya. Dr. Vick serves as the current Ampath Oncology team leader and is a professor of pediatrics on the faculty at IU and Riley Hospital for Children for over 25 years. He's the director of the Childhood Cancer Survivor Program, as well as associate director of the fellowship program in pediatric hematology oncology at IU. He's been traveling to Kenya with Ampath for a decade or more to build the childhood cancer program, and recently working closely with Tyler Severance on improving the diagnosis of childhood cancers. Dr. Severance is a pediatric hematologist and oncology fellow at the IU School of Medicine and Riley Hospital for Children, medical degree from Albany Medical College of Union University, and he's simultaneously pursuing a master's in adult education at IU, which has been a great fit for coordinating the telehealth and education platform that you're going to hear about. I know he was planning to spend much more time in Kenya last year prior to COVID, but fortunately was able to launch this program just prior to the pandemic. And so I guess one of the silver linings, this work and this type of work has been able to continue despite the travel shutdowns and the pandemic. So as a reminder to everyone, please stay muted unless you're asking a question at the end. And we'll use the Zoom chat feature during the presentation. You can put a question in the Q&A or the chat anytime. So with that, let me turn this over to Dr. Tyler Severance. Welcome, Tyler.
Thanks for the introduction, Adrian. I'm going to go ahead and share my screen now. And you guys should be seeing what I'm seeing. Again, I'm really grateful and thankful for the chance to be here to chat with everyone. There are some really awesome people in the audience that I really look up to, and I admire what they've been able to achieve. And so thank you for the chance to share our work. And Adrian, you had mentioned a case about a young child with Burkitt's, and I want you to hold on to that and remember, because I think we'll be able to double back to that at the very end. So again, I'm joined by my mentor and colleague, Dr. Vic, as well as a number of incredible people that I've listed down below who helped make this project happen. And with that, we'll talk about improving the diagnosis of pediatric cancer using telehealth. Tragically, I have no relevant financial interest to disclose. Before starting with objectives in an outline, I actually just want to give a broad definition to the problem that's facing not just Kenya, but the world. If you were to look at it, we recognize that the vast majority of cancer cases occur in low-income or lower middle-income countries. We also recognize that a significant portion, more than 50% of these cases, go undiagnosed. And as we think about childhood cancer going undiagnosed, in your mind, that's a fatal outcome. That is a child that never had a chance to receive life-saving therapy to get cured and to continue living. And so recognize that the vast majority of the world is tasked with helping us address this serious problem. If you look at this map, you can also, and again, this is just an estimate, but we can also tease out the 5-year survival of cancer that is diagnosed. And for developed countries such as Europe and the United States and elsewhere, survival for childhood cancer is upwards of 80%, which is simply remarkable. Four out of 5 children diagnosed with cancer will survive. However, when we look at sub-Saharan Africa and other neighboring regions, we can tell that we still have a long way to go. And so with these two figures in mind, we will transition into our discussion for today. There'll be 4 main components to this for this fireside chat. The first is I want to spend time talking about our background. The needs assessment that went into this educational program didn't just happen overnight. It wasn't just a simple survey. This was 10 years of dedicated effort that went to listening and observing and really living what the community was going through. With that 10-year experience in mind, we will then transition into talking about the ECHO platform itself. What is an ECHO session? What does that terminology mean? We'll talk about how those two worlds collided in 2020 in Western Kenya as we implemented the first pediatric oncology ECHO. To our knowledge, it's the first one in the universe, if not alone the world. But and then the last piece of this, we'll talk about the results. So we'll define what success meant for us, what success meant for our colleagues in Kenya, and then what success meant for our patients. I don't have to really harp too much on this because I know you guys are experts, but the Kenya medical system, we're pretty familiar. Moi Teaching and Referral Hospital has been our gateway partner, the rock that's been a big piece of this. Moi Teaching and Referral Hospital is a comprehensive care center, and it really provides all the pediatric oncology care to children in the western regions of Kenya. If you look at each of these counties, the vast majority of them have district or county hospitals that are actually the gateway into that referral system. So it's these county hospitals that are doing the lab tests, the x-rays, the ultrasounds, that are having the suspicion of a pediatric malignancy, and then making that phone call, making that referral down to Eldoret. Since 2005, Indiana University has been a big supporter, partnering with MTRH to empower them and improve the delivery of care for adult and pediatric patients with cancer. And that's, again, what leads into this discussion. So our needs assessment is going to be broken down into 3 parts. And I think that these 3 parts happen pretty logically. And so I'm excited to kind of expand on that here. The first question that we had when it came to pediatric cancer at MTRH is, were we diagnosing all the patients? You guys saw that figure a couple slides back, but we know that pediatric cancer goes undiagnosed. Because MTRH sees all of the cancer cases for Western Kenya, we recognize that based on the millions of children that live there, we should be able to estimate, based on epidemiologic data, exactly how many patients are presenting for cancer. However, over the course of 10 years, we realized that our observed cases were supremely lower than what we would have expected. That gap of about 80% represents the target population that we were trying to find. These, again, were children that were not surviving a diagnosis and children that ultimately did not have a chance. Among those that are diagnosed, though, cure rates are often as high as 50 to 60%. I put only in that slide, but I want to emphasize a point of optimism that not only is there room to improve on the diagnosis window there, but also we have room to keep going up to reach that 75, 80% pediatric cancer survival rate. So a lot of opportunity to improve. So we recognize that these patients weren't being diagnosed. So the question is, where are they? This slide is a very condensed version of a Herculean effort that was done several years ago by Dr. Vick and by others that asked this exact question. Where are these patients? Are they presenting to medical care? Are they getting any type of labs or evaluations? And the two diseases that were highlighted in this great effort was malaria and leukemia. We know that malaria is far more common than leukemia, but what goes underappreciated is that there's a huge overlap in symptoms here. Malaria and leukemia both can present with fever, body aches, weight loss, lymphadenopathy, and we recognize that both of these require a blood test to diagnose. As part of this comprehensive effort, for which I will claim full credit, even though I was not involved, we saw that there were more than 30,000 malaria tests that were ordered at a single county hospital over a 17-month period. Now, these 30,000 tests were all just answering the binary question, does this child or does this patient have malaria, yes or no? But as you look in the background of those malaria slides, you can also see white blood cells, whether that's healthy white blood cells or malignant lymphoblasts or evil, sinister cancer cells. And through a pretty impressive process of screens and evaluations, they found 41 cases of leukemia that went undiagnosed that were picked up on a malaria smear. And so again, 41 patients that presented with presumably these same symptoms had blood work done, had an evaluation in the lab, but ultimately were not diagnosed. And so as we look at that number, it tells us that yes, these patients are presenting to medical care, but the correct tests aren't being done. The differential is not broad enough, and ultimately the cancer diagnosis is missed. So finally, the last piece of our needs assessment is finding that knowledge gap. Why is it that these patients are being presented, but that one singular next step isn't happening that helps trigger the thought of cancer that leads to that referral? Again, is on the theme of things that have been going on for a long time, for which I'm happy to claim credit, is the annual Ampath Pediatric Oncology Conference. And in January of each year, there's a large gathering of pediatricians from the western regions of Kenya with the singular focus of improving oncology care. We took advantage of this meeting to simply ask these local pediatricians, ask these doctors that are on the front lines, what their perceptions of what was happening. This included two main parts. This included, number one, a general knowledge assessment, standard questions that we would expect a pediatrician in the community to know as it pertains to cancer. And then we also just asked for their interests. What would they like from MTRH, from Indiana University? How can we continue to reach and empower them? And the primary response that we saw was they were hoping for a longitudinal educational forum to continue to build that knowledge, build that mentorship, and build on that collaboration. So again, summarizing our needs assessment, and I know I've spent a lot of time on this, but this is, I think, a critical piece for why we were able to hit the ground running with our project. Question number one, do the numbers add up? Well, for us, only about 20% of pediatric patients with cancer were being diagnosed. Question number two, where are the patients? Well, we recognize that patients are presenting to medical facilities, but the wrong tests are being ordered and the diagnoses are being missed. And then finally, what's the knowledge gap that's contributing here? And local pediatricians, the warriors on the front lines, recognize that there's potential for increased knowledge. And there's also a request, a desire for that increased and continuous education and mentorship. So with those three questions now answered over the course of a decade, that led us to our next question. By finding the intersection of adult education and telehealth, can we improve pediatric cancer care in Kenya? And so pausing briefly, and again, I will cruise right by any questions in the chat. So Adrian, please slow my roll if you see anything pop up. But I think that background is really, really important. So with that context in mind, let's talk about the Project Echo platform. Again, we've referenced Project Echo numerous times, and we are not the innovators or inventors, but Project Echo, or Extension for Community Healthcare Outcomes, is a telehealth educational program meant to connect medical experts at tertiary care facilities with local healthcare providers and medically underserved communities. Now, I've used the term telehealth a couple times thus far, and I think it's important to differentiate telehealth from traditional telemedicine. And anybody who's been in the medical community during the past, I guess COVID's really only been here about 15 months, but in the era of COVID has heard the term telemedicine. You can see telemedicine listed at the bottom. Traditional telemedicine is where you have a medical expert who uses a computer or some type of remote access to communicate with a single patient. That's not the goal here. The goal here is for medical experts. This could be pediatric oncologists. This could be infectious disease experts. This could be a hepatologist. And actually, hepatitis C was where Echo had its origins. But an expert in some field connecting with these primary care teams and medically underserved communities, represented by those red people there. And by teaching and empowering them, those pediatricians, those healthcare providers can reach a greater number of patients, and thus exponentially increasing and amplifying the potential impact of a program. As someone who's interested in education, this is really why I got super excited about this idea. Again, the ECHO program is about empowering and educating these primary care providers so that they are better able to impact their patients. Again, we're looking for the intersection of education and patient-centered outcomes. And I think that's really exciting. So what does an ECHO session actually look like? There's two main components that go into any ECHO session. These are about 90-ish minutes long, shorter if we're a little bit more efficient, longer if I'm talking too much. And these sessions occur about once or twice a month. Occasionally they can be weekly, depending on the needs and interests of the learners or the local healthcare providers. The first component is a scheduled didactic, usually lasting about 20 minutes, and it follows a program or a curriculum. And the second session is actually the most important, and that is case-based discussion. That is a case submitted by the learners, by the healthcare providers, prior to the session, which leads to a facilitated dialogue so that all parties can learn and grow from the case together. When you put those two things together, you got an ECHO session. So what goes into a successful ECHO session? This is, again, I want to spend one slide here just talking about this structure, because I think this is part of the reason why our program was well received. But a successful ECHO model incorporates a hub and spokes design. And when I say hub and spokes, the hub, or the center here, represents the tertiary care center. Hypothetically, let's say this is MTRH. The spokes represent these healthcare providers and medically underserved communities. Let's just hypothetically say those in Western Kenya. What happens is there are multiple pathways for learning and growth as this ECHO community grows together. The first pathway is that these local healthcare providers, these spokes, learn from the specialists. The next is that the spokes can learn from one another. So as one spoke presents a case, their colleagues are contributing and collaborating to help them improve care. And then finally, and I underappreciated this when we first started, but specialists learn from community providers. And I think that is a really great note to conclude on, because it shows that we still have much to learn from our colleagues as well. The fact that this all occurs virtually means that even in an era of a COVID pandemic, we can continue to learn and grow and improve our care of pediatric patients. So again, by finding the intersection of adult education and telehealth, can we improve pediatric cancer care in Kenya? Or for you scholarly types that like a hypothesis, the implementation of an educational program will help improve the knowledge, recognition, and diagnosis of pediatric cancer in Western Kenya. So we've covered number one, the need. We've covered number two, our proposed intervention. Let's talk about how we made it happen. So again, this all started back in January 2020. building upon 10 years of relationships in the regions of Western Kenya with our colleagues that we've known throughout the decade. We recruited in person. There were providers that went to local sites to meet the docs there, to make sure they had Zoom access to this technology, and also to conveniently help them identify potential cases to present as they were joining in. The curriculum was actually pretty straightforward to put together because we had, again, what they wanted to learn. And we also had some of the more significant deficiencies from that initial assessment that was done at that annual conference. To make sure we were staying relevant and on task, we had quarterly check-ins with learners to identify new areas of needs and interests. There was training that went into this, and so we're grateful to our sponsors and colleagues who helped make this training happen. This primarily consisted of immersion training. As I mentioned earlier, we were not the innovators of Project Echo. This has been in existence for about 20 years and was born out of Albuquerque, New Mexico. And so we had a couple of our team members, including some that are here in this call, travel out to Albuquerque to learn about the Echo model and how to make sure it runs smoothly. And I will also admit that there's a little bit extra practice and training that's needed for facilitators and coordinators. So that was key. And then finally, I just want to mention this Zoom platform, the one that we're using now, is perfect for something like telehealth due to low costs, and it's really easy to use even in isolated regions. And so, as I mentioned, in January 2020, we launched. We actually had a test run during that conference that I had mentioned. So we got to pull our participants, our audience in to see what it was like to have an Echo session in action. And I think that was a big help for recruitment. The focus of our Echo, the theme for the year, was again, the presentation and initial diagnostic workup for common pediatric cancers. Thinking back to that graph, our goal is to target those 80% of kids that are not being diagnosed, and you'll see that reflected in our curriculum. The hub team was based out of Eldoret with medical expertise from Indiana University and Riley Hospital. And again, this project absolutely would not have been possible without some of our wonderful colleagues across the ocean. And so now perhaps the most important is, was this successful? What did we learn? What did we find? So in 2020, we had a total of 22 Echo sessions with 151 different participants or unique participants during the year. We averaged about 22 participants at each session on average. Our curriculum, like I said, was built upon the needs assessment, and we got to adapt as the year went on. The quarterly reviews helped us kind of fine tune our product and make sure we were continuing on task. You can see this map on the right side of the screen. The counties in red were those with frequent attendance. Those in green they were there. We have a little room to improve. And those in yellow are that's kind of our ideal scenario. Eventually, we hope to continue expanding. This graph shows our participation over time. Again, you can see we probably averaged about 22 participants at each session. You can also probably suspect where COVID entered the forum and attendance was a little bit more erratic, including a peak of 40 participants at one well-attended session. But even at the end of the year, as business returned to normal, we still had a good core group of attendees. We did ultimately send a survey out. I guess many of you guys have done incredible work in Kenya, and I'm sure you've encountered this barrier. Both Kenya and I would also argue the US are not great at following up on electronic surveys. So we did the best we could. There was a couple key highlights that I just wanted to share. From this session, you can tell that, again, our goal was to improve knowledge, comfort, and ability to diagnose pediatric cancer. And I think we really, or at least in the perspectives of our targeted learners, I think we hit the mark on that, as the vast number of our responses were favorable. Continuing along, we also wanted to highlight the academic side of this. Will they continue participating? Would they feel comfortable presenting? And a big part of education, did they enjoy it? They're giving up their valuable time to attend these sessions, and did they enjoy that experience? And I think from these responses, our answers are pretty favorable. So again, this covers evaluation 1, which is, did our learners have a good experience in the process? The second piece of this is patient care. And I think this slide is perhaps the most important because this talks about new pediatric cancer cases. So in a year where COVID just totally disrupted the healthcare landscape, and in a year where there were all kinds of crazy things happening and comings and goings and travel restrictions, we had 286 new pediatric cancer cases at MTRH, which represents not only a 13% increase from last year, but a 33% increase over the 3-year rolling average of pediatric cancer. And to put this number in perspective, that 286 new pediatric cancer cases is more than Riley sees in a typical year, which is, it's just still mind-boggling to me how incredible and effective our colleagues are from Kenya. With the year concluded, we get to talk about looking forward. So we'll look at those 286 new cases and compare it to our cancer registry. Again, if time permitting, would love to look and see if the counties that had increased attendance, those good areas on the map, had an increased diagnosis relative to their peers. But again, that's if there is time. And so as we address our underlying question, by finding the intersection of adult education and telehealth, can we improve pediatric cancer care in Kenya? I think the answer is yes. And that this is just really, really exciting to me. The great piece about Project Echo is that it's easy to replicate and disseminate. And so I'm biased, but based on the success of the program, I think there's momentum to continue and expand efforts. We are seeing the continued evolution of this program. Year 2 is now underway of this Pediatric Oncology Echo. And if anybody is interested in staying up, the next session starts in about 6 hours. Anybody here is welcome to attend. I think I'm actually giving the didactic today on bone tumors. Again, all are welcome. There's also been the launch of a multiple myeloma and a palliative care echo, which are, although in the infancy stages, are just poised for incredible success. And then looking into the future, breast and cervical cancer, I think would be a great multidisciplinary echo, and sickle cell disease. And hopefully that will be launching in January of 2022. I also want to give a quick shout out to the potential for reciprocal innovation. The Fairbanks School of Public Health has more than 10 echoes that have been running out of Indianapolis for the last several years, including a general cancer echo with many overlapping personnel. And I think as we have grown and learned from our experiences in Kenya, we've been able to take some of those same lessons and augment our academic work here in Indianapolis. And I think that's been really, really awesome. So Adrian, you had mentioned a young child with Burkitt's, and I wanted to double back to that comment. I think that hearing about Project Echo is one thing, but seeing what it looks like is totally different. And no, I'm not savvy enough to put a video clip into a PowerPoint slide, but I was happy to pull one of my favorite cases from the past Echo session. So this is our typical template. When we talk about spoke-led case presentations, this is it. They submit us a case in real time, a day or two before the Echo session, and we put it all together as a single slide. They walk through, and the group gets to ask questions and then kind of collaborate on recommendations. And for this child, there's a couple. This was presented, I think, August 26, 2020. And this focused on a 3-year-old child who came in with a chief complaint of abdominal swelling, some abdominal distension, watery stool, vomiting, lasting about a week. On exam, I'm just hitting the highlights here, but on exam, he was sick looking. He had a distended abdomen, and he had a palpable mass in the right and left upper quadrants with some cervical and inguinal lymphadenopathy. And when we look at a patient like this, and again, this was a child that had been seen and evaluated, but was unclear on next steps. And ultimately, this child was presented, and the recommendation from not just MTRH, but also their colleagues was to refer this child for diagnosis of a presumed malignancy, immediately. And ultimately, this child was found to have Burkitt's lymphoma. And Burkitt's lymphoma can be a rapidly progressing disease that is fatal if not navigated quickly and safely. And the initial care needs to be at a tertiary care center. And this case is the exact type of patient that we're hoping to capture. This is a patient that presented to a medical facility with complaints, and they have a finite window to get that diagnosis of pediatric cancer, or this child won't survive. And if a little bit of knowledge, a little bit of mentorship, and a little bit of collaboration can be that last piece that gets this child referred, gets them treatment, and gives them that chance, then I think Project Echo is 100% worth it. And again, I keep going back to your story, but I think that this is a really good highlight, so you can see what an echo would look like in real time. As I conclude this just brief discussion, I wanted to thank so many of the wonderful people that made this happen, including a number that are in-house today. The Echo community is wonderful. That license is free to use, and we wouldn't have been able to do this without them. I know that IU and Ampath have been a great team with MTRH, and I am just getting to know the surface of that relationship and that bond. I also want to just acknowledge the support from Takeda. Again, there's a lot of financial support that goes into this, and these things just simply are not possible without some excellent community partners. I'm not going to continue to name these all, but I just am really, really grateful for folks that made this happen. And so now, as we transition into our discussion, my two questions that I would like to leave you guys with is, number one, what is the role of education in improving the care of patients in medically underserved communities? And number two, can telehealth help us to move across borders and really bring our global community closer together? And then, of course, I'm ending with a quote from Carl Rogers, one of the founders of the humanistic perspective in adult education, that the purpose of adult education is to help them to learn, not to teach them all you know, and thus stop them from learning. And so with that, I'm just thank you guys for the chance to present. Oh, this is the obligatory family picture to prove I'm a normal person, including our daughter in a Moana swimsuit. But again, thank you guys for having me here. Thanks, and thanks for your time.
Tyler, thanks so much. As much as we like to look at your daughter, why don't you maybe put those questions back up so people can look at the questions and consider some thoughts as I just give Terry a little opportunity here. Terry, this is obviously, as Tyler mentioned, sort of happening in the context of a larger pediatric oncology effort that you've been a part of for a decade or so. I don't know if you would want to expand on the fellowship or the clinical service or any other aspects though.
Yeah, I think, thanks, Adrian. Thanks for your background for all of this work, Tyler, because I think what people have heard is the focus that we've had at Ampath and MTRH for the last decade. You know, the needs in Kenya, for all who have been know how much everything is needed, and trying to prioritize what do you do first. The sequence of events, trying to first prove that there's a problem and then get people interested in trying to solve the problem, and yet getting local buy-in to do that. You know, we've done it on lots of different levels in Kenya, making sure drugs are available to treat the kids. So the drugs that we use in Kenya are the same drugs that we use in the US. The drugs that we have available in Kenya are enough to push survival to 75 or 80%, especially with the advent of radiation therapy in Kenya. What it really is taking is a lot of ability to transfer that knowledge and interest into learners within Kenya. And we've talked about the local levels, all the medical officers, clinical officers on the front lines trying to make a diagnosis. But even at the highest level, there just now has been a pediatric hematology oncology training program that started at Moi University a year and a half ago, and our second class of fellows is now there. So we have 4 fellows learning to be pediatric hematologists, oncologists, as the first 4 fellows trained in Kenya to be pediatric hemonc doctors. So the interest in the population, the healthcare facility, the university, the Department of Pediatrics to to make this happen. I've helped facilitate that, but it's really the people there that have seen the need and forced the issue. And so we're beginning to train the first cohort of leaders in peds hem-onc who will have training. As Adrian said, we've built a lot of different things with the Chandaria building for outpatient care in hematology and oncology, as well as other chronic diseases. The Shoe for Africa Children's Hospital, that was possible because of fundraising by Toby Tanzer. And I think our partners in Amsterdam, Gertjan Kaspers and his team from the Netherlands, has had a long-standing focus in Kenya as well, and we've been very good partners together to work on all these things that Tyler's talked about. And I think it's sort of the next level for us is to think about trying to figure out how to build and outfit a pediatric cancer hospital specifically. And we have funds that Toby has raised through his Shoe for Africa Foundation to build a building, and my Dutch colleagues are working to raise more funds to outfit the building so that it will be a state-of-the-art cancer treatment facility for children in Kenya. And all of these efforts just have been a decades-long process that will need to continue for the next 1 or 2 decades to kind of get it to where we need to be. And I'm just very proud to have been able to be a small part of that and to keep pediatric oncology on the forefront, because I could throw up lots of pictures of patients we've seen over the years, but I do have survivor pictures. I should share them with you, Adrian, so that we can give them to Bob, so that we have lots of kids now who we've treated with BRCA, treated with leukemia, treated with osteosarcoma, and they're long-term survivors. So I think the nurses, the doctors are seeing the results of all their hard work, and I think it's making them energized to continue to make progress that way. So I think I'll probably stop there and see if anyone has any questions for us.
Yeah, that's great. Amazing work, guys. So I'm gonna respond to your question. Or Tyler, turn that first question back on you with a question from Mark Bauman, who's posted in the chat. And just thinking about, and Terry, feel free to chime in here too. But education is clearly a hugely important part of this. And as you pointed out with your example of then just looking as simply at the malaria smears, and picking up a misdiagnosis is just actually astounding to know that a relatively cheap, low tech, low cost test can actually pick up some of this stuff, or at least give an inkling of it. But education is not everything, right? So there's a whole sort of, when you're building an oncology program, sort of got to go from, building the diagnostic capacity, ultimately, educating providers on what to do with the diagnosis and make the treatments available, train people how to use those treatments. Palliative care is part of that story as well. So Mark's question is just, discuss the role that pathology services at MTRH have for definitive tissue or bone marrow diagnosis of malignancies. And how is that an important part of this puzzle?
Yeah. Go ahead, Terry.
No, I didn't talk about that because it's a whole another session on its own. I think for the change in the past 10 years, the ability to have high-level cancer diagnostic tools has been critical. So in the adult cancer world, the fact they've been able to procure equipment to do immunohistochemistry to help diagnose and subclassify adult leukemia or adult solid tumors, breast cancer subtypes, myeloma, other colon, lung, cervical cancers, that technology has been incredible. I've been more focused on liquid tumors and leukemia, and so we've we've made a strong effort to build up flow cytometry as a way for leukemia and lymphoma diagnosis. And one of my colleagues, Gail Vance, has spearheaded some work in genetic testing for particular leukemia diagnosis testings for Philadelphia chromosome, for chronic myelogenous leukemia, and for the translocation present in Burkitt lymphoma. So that is growing, as well as the clinical programs, and we focus on all of that. And I think the problem for all of these things, though, is that they cost money. So right now, the National Health Hospital Insurance Fund has been willing to cover radiology services, but they really haven't bundled any cancer diagnostics into things. And Adrian was at the meeting with the CEO of MTRH just before we left, just earlier this month. Hasn't been that long. Where we're trying to get people to think about the idea: can you, if you have a service that's available only at a high level referral hospital like MTRH, can that hospital be a center of excellence for diagnosis and treatment and care for patients with cancer? And perhaps that might be a way to leverage the current healthcare system to cover costs for patients in the public sector at the referral hospital, as opposed to just covering somebody who says they have a flow cytometer that can check two different surface antibodies, CD4 and CD8, to see if they're on leukemia cells. So it's a long-standing big problem that I know many people are working on from lots of different levels, but just training technicians to be able to run the tests is a whole nother level of problems and training and infrastructure that is being built. So we won't talk about that much more, but I don't know if Tyler has anything else you want to add to that. You've gotten to see it on a limited scale, but it's definitely there.
Yeah, I would just emphasize that Project ECHO is meant to be multidisciplinary and inclusive. And Dr. Latoto has been a frequent attendee, and her perspective has really helped, again, augment some of the discussion, especially for some of the challenging cases. And so again, I think it all comes down to that collaboration and teamwork.
Yeah, Teresa Latoto is a hematopathologist at Moy University and works at MTRH, and she's spearheading pathology services and trying to empower county hospitals to do bone marrow aspirations, to gather samples, transport samples, so that patients don't have to travel to MTRH, that we can just get samples that are properly processed and transported to us in a timely manner, so that we can make a diagnosis and then potentially work on the referral at that point. So she's been a very big partner in all of these efforts as well.
Yeah, and of course, Mark is working closely with her and with other pathologists at MTRH and Moy University to try and improve those services. So let me invite anyone on the call who wants to come off mute and ask a question or make a comment. We're nearing the end of our time here, but if not, then maybe Tara, Tyler, you maybe just make one sort of final comment on just the challenges that lie ahead. Tyler, I know this was a sort of a project, but is this going to continue? Is this technology going to sort of persist, and how are you going to use it moving forward?
So I think that it's something that, again, once it has momentum, it's up to us to keep it going. I think that it's really being driven by the learners at this point. So there's been a really strong interest from these healthcare providers. I think they're eager to contribute thoughts, ideas, cases, and I think we can keep kind of building on our curriculum. So again, the topic for this evening's echo is bone tumors. Osteosarcoma is not one of the more common cancers, but it does happen, and there's potential there. So I think we're gradually kind of expanding that knowledge base. I think that, or at least my impression has also been that once you have one echo, it's easy to add a couple more. And I know that's easy for me to say because I have my bedtime is 10, 11 o'clock and I get to wake up and I only have to stay up, for two nights a week or a month. But I think that expanding to other chronic diseases makes a lot of sense. And I was really impressed by what Ampath was able to do in my very limited time in Kenya. And I think there's just so much potential. Funding and resources is a little bit of a challenge. So we do have to keep advocating and make sure that everybody knows how grateful we are. And, but I like to think that there's positive momentum moving forward.
I will add that for what it's worth, our first echo that we had people joining from Nairobi and from Lamu, trying to figure out how to refer patients to Eldoret. So I don't know what that portends for the future if people from the coast want to send their patients to Eldoret, but it was a scary thought. And I think the other point to be made, as Tyler said, the people who are interested, it just builds on itself. And Tyler has just gotten some funding to launch the sickle cell echo that's going to happen in Kenya with many of our partners who are interested in benign hematology problems, sickle cell being a huge problem. And so he's now got both feet in the water and soon will be drowning in Kenya projects. So that's good.
That's great. And I know you guys are aware that, Ampath just got I think it was a $90,000 award from ECHO as well to sort of expand and bring on more sites. So,
yeah.
George, thank you very much for the comment and for joining us tonight. I think that you may be interested, if you haven't heard already, about our mental health work. Feel free to reach out to us and we can connect you a little bit more with some of that work. But we've reached sort of our time here. So I just want to thank Tyler and Terry for sharing your incredible work and the impact you're having on kids and families in Kenya. And thank everyone really for tuning in. This work relies on the support of people like you and the donations that allow Ampath's work to serve cancer patients and their families. We're of course grateful to our Kenyan collaborators and also the support of a number of partners, including Takeda and Eli Lilly and Company, the Indiana Hemophilia and Thrombosis Center, Project ECHO, Fairbanks School of Public Health, the Indiana CTSI, Regan Street Institute, IU Health, and of course the Riley Hospital for Children. If you're interested in supporting the initiatives we talked about today, please feel free to reach out. And just a quick plug, I know it's in the chat, but our next month's Fireside chat is entitled Global Health is Local Health. And we're bringing back co-founder and star Bob Einherz, who will be interviewed by actor and Ampath advocate Jesse Spencer, who plays a doctor on TV, about his transition to health officer at St. Joe's County and how Bob's applied the global health lessons locally over the past year, and especially during the COVID period. So that'll be Friday, July 16th at 12 o'clock Eastern time, 7 p.m. Kenya time. Again, thank you everyone for joining us and for your partnership with Ampath. Have a good evening.